Hi everyone. Today we're discussing impetigo, a highly contagious superficial skin infection. You'll typically recognize it by its most distinct feature, erythematous lesions covered in a signature honey-colored crust. While these lesions are usually asymptomatic, patients often report that they can be quite itchy or pruritic. The process starts quickly. What begins as simple macules and papules rapidly fill with fluid before rupturing. Because it is so contagious, it spreads easily through direct contact, either to other people or to different parts of the patient's own body through a process called auto-inoculation. In clinical practice, we distinguish between three specific types. Non-bullous impetigo. This is the most common form. It features small vesicles that burst so quickly they're often already gone by the time a clinician evaluates the patient. Bullous impetigo. You'll see large, flaccid bullae. In both this and the non-bullous type, once those fluid-filled lesions rupture, they leave behind a superficial erosion. Eczema. This is the more severe subtype. These lesions extend deeper into the dermis, resulting in painful ulcerations with distinct violaceous or purple borders. Diagnosis is usually clinical, meaning it's based on those characteristic skin findings we just mentioned. However, a bacterial culture and sensitivity test become necessary if there's a localized outbreak, if we suspect MRSA, or if the patient isn't responding to initial treatment. For recalcitrant or recurring cases, we should also perform a nasal culture to check if the patient is a carrier of Group A strep or Staph aureus. When it comes to treatment, topical antibiotics are the gold standard for limited infections. They are actually equal to or even more effective than oral meds. While impetigo is technically self-limiting, we always recommend treatment to stop the progression and prevent it from spreading to others. Important note: disinfecting agents do not have proven efficacy here and are not recommended. We save systemic, oral antibiotics for specific cases, eczema, which can cause scarring, widespread infection, or if the patient shows systemic symptoms. Finally, we must watch for post-streptococcal glomerulonephritis. This kidney complication can occur if the infection is caused by a specific strain of Group A strep. It is a serious reminder of the importance of monitoring, as, unfortunately, this specific complication is not prevented by antibiotic therapy.